Oh, morning everyone. Welcome. Oh. So we'll get started, I think everyone here that's come in. So I'm Dr. Linda Colley. I'm the Clinical Director for Health and Care Portsmouth, which is part of the Hampshire and Isle of Wight Integrated Care Board. I would particularly like to welcome two new councillors to the board this year. So Councillor Steve Pitt, who's leader of the council, and Councillor Graham Heaney, the Labour Group representative. Unfortunately, they have sent their apologies today, so they're not actually in the room, but I still want to formally welcome and obviously thank the councillors who have stepped down from the board. Limited public seating has been made available. However, this meeting is also being webcast to allow the public to attend remotely if they so wish. So just a bit of housekeeping. So if the continuous fire alarm sounds, please evacuate the room and the public gallery by the stairwells. Do not attempt to use the lifts. Please assemble by Queen Victoria's statue in Guildhall Square. In order to comply with the Guildhall Trust fire marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. For the live web streaming, may I draw everyone's attention to the fact that it is being live streamed. Everyone speaking via microphone will be on camera, including those making deputations. Members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphones and remember to switch them off when they have finalised speaking. So there's just a button on the side if you're not sure. We've read the report, so presenters, please just highlight any developments that have occurred since the publication. And we're going to now go round for introductions. So if we start over with Matt.
Councillor Matthew Willington, Cabinet Member, Community Wellbeing, Health and Care, and the Co-Chair of the Health and Wellbeing Board.
Thank you. Terry Norton, Deputy Police and Crime Commissioner for Hampshire and the Isle of Wight.
Councillor Lewis Gosling, the Conservative rep on the board.
I'm John Sparks. This is my first meeting. I'm Medical Director for Solent Adult Services in Portsmouth.
Morning, I'm Jo Pinhorn. I am the Deputy Chief Operating Officer at Solent, and I'm here representing the Chief Operating Officer.
Hello, I'm Helen Atkinson. I'm the Director of Public Health, Portsmouth.
And I'm Kelly Nash and Strategy Team of Portsmouth City Council and provide support to the board.
Morning, James Hill, Director of Housing, Neighbourhood and Building Services for Portsmouth City Council.
Councillor Susie Horton, I'm the Cabinet Member for Children, Families and Education.
Jo York, I'm Hampshire and Isle of Wight ICB Director for Portsmouth and also have a joint role with the local authority here.
I'm Sarah Daly, I'm the Director of Children, Families and Education here in Portsmouth.
Hi, Roger Batterbury, Chairperson, Healthwatch Portsmouth.
Good morning, I'm Innes Richards. I'm deputising for Lorna Reevely and I'm from Hive, Portsmouth.
Good morning, Chief Inspector Andy MacDonald, Hampshire and Isle of Wight Police.
Morning everybody, David Williams, Chief Executive, Portsmouth City Council.
Anna Martin, Democratic Services.
Thank you. And I've received apologies for absence from Councillor Graham Heaney, Councillor Steve Pitt, Sarah Beattie, Andy Biddle, Penny Emmerett, Paul Markham, Kirsty Ranford, Lorna Reevely and Paul Riddle. Is that correct? Lovely, thank you. So moving on to the agenda today, do we have any declarations of interest? No. Minutes of the previous meeting on the 15th of February. So I actually wasn't here for that meeting, so I'll rely on all of you for accuracy, please. So page 1, first of all. Page 2. Page 3. Page 4. Page 5. Page 6. Page 7. And page 8. Is everyone happy that they're accurate? Yeah. Fantastic, thank you. Were there any actions arising from the manner that you were aware of? No. Fantastic, thank you. So over to, who's doing this one? Jo York, Integrated Board.
Thank you. So the report that we've got is from the Integrated Care Board and it sets out the draft a joint forward plan, and the joint forward plan each ICB is required to produce, and it sits alongside the integrated partnership, Hampshire and Isle of Wight integrated care partnership strategy. So this is really for noting for the board and to the board to continue to support the development of the plan. And I think lots of people have been involved around the table, Sarah, David, Helen, with and Matt, around the integration, the development of the integrated care partnership strategy. This sets out how NHS services will be delivered in line with that strategy, but also the ICB's priority, particularly around some of the finance and recovery actions in the first year around some of our key transformation programmes to improve services, but also to tackle some of the financial challenges as well.
Is there any questions or comments for Joe?
I think. Sorry. Helen.
No, you go first, David. No.
What I would say is I think it's really important that at the moment there's quite a difficult position, a very sensible strategy and some very big financial and general resource pressures. I think it's really important as we go forward that the voice of place comes through really loud and clear, both to influence the strategy, but also to influence the relationship between the strategy and the resources. Because without that, and this is absolutely full of priorities, to the point that there isn't a lot that isn't a priority. And I think that's something that this board should really keep a very, very close eye on and try to make sure that the emphasis is going to be on things that are really going to make the most difference for local populations. And there are going to be some big battles, I suspect, around what we mean by that in terms of equity, equality, worst first. There'll be all sorts of different models of resource distribution. It's vitally important that the cities and the local communities influence that in the future and try to distill that myriad of sometimes conflicting and competing priorities into something that's going to be more workable. Thank you.
Thank you.
Thank you. Actually, it nicely follows on from David's point. So I would just like to, I feel I can't not say that, and this is, can I just make this clear that this is not a comment, I would like it minuted. This is not a comment back to the local ICB team, but when I look on slide 16, which has got the local place priorities, I would like to say that we did formally raise that they were not, in the original version of this, the Portsmouth priorities that we all agreed as Health and Care Portsmouth. And although I recognise them now, they are a subset of what we agreed. And also the reason I have to say something as Director of Public Health is there's another mention of health improvement and tackling health inequalities. It's implicit, but that was one of, in fact, it was our number one priority. So I just formally would like to say that, but I just want it clearly noted that this is nothing to do with Joe and the local team, and Kelly did formally feedback.
Kelly?
Yeah, I mean, probably just to clarify that, so exactly as Helen said, they're a subset of the ones that we've submitted, and those priorities were set out in the plan that's actually being developed at the moment, and I think it will be coming to the Health and Wellbeing Board in September, so that will set out in more detail the local priorities and the actions underpinning them. So, yeah, exactly as Helen said, it's not a huge mismatch, but we will be clarifying those in the September meeting.
Thank you. Councillor Winton?
Thanks. And I think actually what has just happened with both David and Helen's contributions and Kelly's as well is one of the things we have to be very, very conscious of going forwards, which is to make sure that what our priorities are here that have been agreed here and not being fed into the into the integrated care system, Hampshire and Isle of Wight wide, are reflected and fed back. At the partnership, so myself and Andy Biddle sit on the Integrated Care Partnership Committee, and one of the things that comes out there when we had our first meeting earlier this year was about the fact that it's all very well having words, but actually it's about the actions. So as David said, there's an awful lot of priorities in here, but for all partners, so whether it's statutory sector, so especially whether it's councils or any part of the statutory NHS sectors or any other partners who have the money to deliver this, it really does need to fit into those priorities. And then obviously we have obviously other partners like the police and the fire service and probation and all the other partners we have locally as well, where we're actually more unusual because we have that partnership locally, and that's becoming more of a thing that we're having Hampshire Isle of Wight. We're actually in a really good position in Portsmouth because we've merged all our Community Safety Partnership and our Children's Trust Board into the Health and Wellbeing Board. In the rest of Hampshire Isle of Wight, that does not exist. But the Integrated Care Partnership is that, of course, including also the voluntary community and social enterprise sector, who, as we know, with the Hive here and all our other partners across that are really key to that. So we do have a lot of, it looks nice, doesn't it? It does look nice. It's nice and colourful, has lots of priorities, but actually it's about, and it might say, well, we're thinking of doing this, but as David said, you can do these things in different ways. You can do it in a Hampshire Isle of Wight level, which has no sense of place, or you can do it at place level. Of course, the irony is, everyone, when we speak at the Integrated Care Partnership Assembly, when we talk to all our partners, they all say place is key. So for us, that's where we keep pushing, and we work with our partners at the local authorities. We work with our partners within those other organisations that are positive towards place, and we keep pushing for that, because otherwise it could be very, very easy. You could deliver these priorities, but at a Hampshire Isle of Wight level. So that's really our key thing, and it's about us working in Portsmouth, but also with our partners outside Portsmouth, because they all feel the same way as well. So happy to accept this through with the proviso, as Helen has mentioned, but the frustrating thing is we have to do this. We have to keep looking and going, hang on a minute, that doesn't reflect what we've done locally. We've got our we've got our health and wellbeing strategy, which feeds into the integrated care strategy and all these strategies that the Hampshire Isle of Wight ICS do. But in the same way as we are reflecting what is in that strategy, they should be reflecting about what's in our strategy. And if we don't see that, then we have to pull up and say, hang on a minute, that's not what we agreed. And we have done as you've asked in terms of integrating that into our health and wellbeing strategy, and therefore the other way should happen as well. So it's, as David said, this is interesting times. There's going to be lots of pushing and pulling, and we're going to hear a bit more coming up about fusion as well. And that could be another bit of pushing and pulling, because it's got to be about us keeping our focus locally, but also recognising our partners around the rest of the county feel exactly the same way we do as well.
Oh, thank you. Roger?
Thank you. I agree with all the previous speakers. I think very important that we consider place and the people of the city. I'm just a bit concerned about the financial context, having been in a meeting recently, finding out that the chair of the meeting had taken Mars and was leaving on the Friday, and I think there's more ICB Portsmouth staff leaving at the end of the month. I've heard that the cost savings are 20% this year for Portsmouth and 30% next year. So just expressing a cause of concern about the savings, potentially affecting patient care and the provision of services. You know, staff leaving is a shock. I wasn't expecting that. So just making those points. Thank you, Linda.
Thank you. Joe, did you want to come in and then?
Yeah, so I think taking sort of David, Matt and Helen's points first and then yours, Roger, specifically around the ICB. So I think that there is an opportunity for, this is still a draft report, although it you know, they're aiming to get a good draft done by the end of June for sign-off in July. There is still the opportunity for us to formally feed back our comments and for those to be considered, and particularly around the priorities, because we did feedback that and it still doesn't feel like it's landed in the way we would expect it to be recognised. So again, I think we can feed that back through the Health and Wellbeing Board. And the other comments around place. One of the things we've discussed in a number of forums and are trying to progress over the summer with ICB colleagues is what is the operating model around place in each of the 4 places? How does that sit within the ICB? Because there are certainly advantages of being able to work across Hampshire and the Isle of Wight and do things at scale, particularly where we have some of the financial challenges across all of our areas. So, but I think we need to be clearer about what we do where so that we can continue to work in partnership and continue to do that really well. So those workshops are planned over the summer. I think there will be one for Portsmouth with perhaps wider ICB partners to come and hear what our ambitions are at place and what our plan is for our place. And then where we come together and compare and contrast and what does that tell us around each of the 4 places and where can we come together. So I think that will be happening in the background. I think that will be really important to us, and getting our voices there and listening to other colleagues across the ICB and the ICS as well. And David and I are sort of progressing that before he goes. So, but I do think maybe we want to, and happy to work with Kelly about how we feed back some of your comments today so that they are formally fed back. Roger, with regards to the ICB position, all ICBs have been asked nationally to reduce their running costs by 30% from 24-25. So I think for Hampshire and the Isle of Wight, given our financial challenges, but also we haven't yet reached the benefits of bringing 4 or 6 CCGs together into a single organisation. So the MARS scheme, it stands for Mutually Agreed Resignation Scheme, is an opportunity for staff before we go through any organisational redesign for people to make a choice around whether they want to leave, and there's a settlement, and all of that is you know, very much at the behest of individuals and their privacy around how they want that to be shared. We are very cognizant, though, that does mean right across the organisation it leaves us with a number of gaps. So we are working really closely, both as a Portsmouth team, but across with other teams around how do we fill those gaps, what interim pieces can we put in place, whilst we then do an organisational redesign piece, which will need to be full consultation with all of our staff. So there will be some interim arrangements, and we will be looking at how we pick up the work, but also how we work more closely with our partners, both the local authority and Solent, because often we have staff doing very similar things, or they're trying to do it together, but actually are we now at a point where we can say actually this person can do it on behalf of? So they're the conversations we're having to try and reduce those gaps, and again both locally and across the organisation. We can perhaps pick up more of the detail of that in our Health and Care Portsmouth Partnership Board around how we're filling the gaps perhaps in the immediate term and in the interim. Thank you.
Thank you, Sarah, and then Ines.
I think when we moved into this integrated kind of partnership, our concern was about levelling down, not levelling up, and the losses that we would have as a city, being such a strong integrated city with really positive partnerships and ways of working already well embedded. I think the way that we work in place and the way that we don't wait for that whole footprint to move, but I've got the page open on 1001 days. I think as a city of Portsmouth, with the inequalities, with the health inequalities, with the deprivation in the city, we need to grab that priority and we need to make it work for us in place, and we are already doing that. And I think that reassurance that we're not waiting for the whole of the ICS, we will lead on this and we will support others to come with us. But we have to take control and we have to be mature and we have to say we will lead. We will show you how you can do this better, and we will lean into you and support you to do this in the way that we are doing it in Portsmouth. But we have to be proactive and we have to be strong in that partnership, and we have to make sure we're sitting in the right meetings, that we're present and that we have that voice. And I think more and more so we are confident in that area. So I think that reassurance is there, that we are not sat idly waiting, we are moving forward with the plans as we want to. But it is important that the work we're doing is reflected strongly in the reports that come out, so that the city and the people of the city can see that and will feel that and will understand what we are doing.
Thank you. Ines?
Thank you. Slightly separate point, but valid, I think, in this discussion. Hive Portsmouth and others, some of whom are around the table, have been working with the ICS to build the HIVCA, which stands for something like Hampshire and Isle of Wight Voluntary and Community something, but it's the network of VCSE that interfaces with the ICS. It's an ICS-led programme. And ICS colleagues have been quite rightly going and discussing with partners, and part of our feedback has been about emphasising the importance of building not just the regional infrastructure of the HIVCA but also the place-based structure as well. And I think it would probably be quite wise for this board as well to pay attention to how VCSE is locally integrated and democratically represented in its structures in place, as well as in the HIVCA, because I think that will add another voice or another set of voices to some of these discussions around strategic priorities, both in place but also influencing stuff that's happening at the regional level.
Thank you. Jo, did you want to come back?
Yeah, no, I think that's really helpful, Ines. And as Kelly said, we're doing a lot of work on our Health and Care Portsmouth plan and how that links to the strategy and the priorities at an ICB level, but also what that means for us locally. What are we taking forward? How are we improving our services? So I think we would be in a position to bring that back to the next board that will then hopefully be really clear about what our priorities are and how they link in and feedback, and we could perhaps include some of the role of the VCS within that as well to make that link.
Helen and then Kelly.
Again, adding, I think I don't want to give the impression that we're being done to, because I think building on exactly what Sarah says, there are a lot of people in Health and Care Portsmouth who are actually supporting ICB development. So Jo very kindly mentioned the ICP strategy, which we've all been involved in, but actually it is, I'm going to say, local. It's pretty much local government, Health and Care Portsmouth and Health and Care Portsmouth staff who've been contributing to those across the whole piece. So not only has obviously Hayden and Sarah's team been leading the children's and had the opportunity to influence, if you look at the sub priorities, for instance, the so mental health, emotional wellbeing, the DPH from Hampshire's leading that, CVD, it's the DPH from Southampton, and actually working very closely with Ines, Lorna and Hive, we've been leading on, and I probably wouldn't have called it this, but that's fine, and I keep forgetting what it's called. That's it, social connectedness. I would probably call it tackling isolation, but it's called social connectedness. So I think building on what Jo and Sarah, I don't want people to think we are very much at the forefront of influencing and actually now leading on quite a few of the ICP priorities, aren't we, Jo? Which is really important.
Kelly?
Yeah, and I think just to follow up on that, we've made references to bringing the priorities back in the next meeting. I think that shouldn't be taken to mean that we're not very clear locally around what they are, because I think you've heard from those around the table that we really are. What we haven't done is probably put them in a digestible format for that wider communication piece. So that's what we're bringing back. But as I say, I think it absolutely reflects the shared priorities that everyone's very clear around the table.
Debbie?
It's just to come back on the point about the HIVCA, if that's okay, and it's just to sort of, I think, to make sure that a politician of sorts is cited at some point on the developments there. It's going to need somebody to be lobbying in. It's going to need some, you know, there's no elected mayor in Hampshire, so it will probably need someone that can have those connections in there. I'm not sure if that's a local politician or, you know, I mean, realistically, what choice do we have? But so that there is somebody that's able to really raise that agenda, to get in there and raise that with the various government departments. But, you know, somebody probably needs to grip that from a political perspective.
Thank you, Matt.
Yeah, so we had a presentation about this at the Integrated Care Partnership steering group at the last one. We've got our next one later in July. So that's already been discussed at that forum, and that will be at that forum because that fits in and it joins in with the partnership. So that's obviously, and just to sort of reiterate for those who don't know, the Integrated Care Partnership is currently chaired by my counterpart as Political Health Wellbeing Board Chair and Cabinet Member from Southampton, and will be moving through in on a rotational basis, on an annual basis, for the chairs of the political chairs of the Health Wellbeing Boards for the four primary Health Wellbeing Boards. So that's the forum whereby that work is feeding into, and as I say, we had that very initial presentation at our meeting. I think it was back in March or April.
Thank you, that's great. So who, if people have got concerns and they want to raise it so it can be escalated, who would we go to? Kelly, or who wants it? Don't know. Is that all right? Yeah, and obviously quicker the better because we're on timescale. You said end of June, so that's Friday, isn't it?
Yeah, so I think we can obviously through the minutes reflect some of the comments that we've got, but if people wanted to add anything, and Kelly and I can work together to take that, and also to share again the priorities that we've shared and have that conversation about they're not quite landing right with us. How do we resolve that issue as well? So yeah, any more comments that people want to make, if they send them to Kelly or I in the next day or so, we'll get that letter in, and then we can probably send it round with the minutes next time.
That's great. Thank you very much. So moving on to Health and Care Portsmouth Project Fusion, and I believe it's Jo who's going to do this one.
Thank you, and my colleague John, who's our Clinical Director in Adults Portsmouth, will also be here to answer any questions as well. I'm not sure about how much people know. This is my first meeting, so I'll just give a brief overview first of all, and then any questions that anyone might have. So we are working on a programme of work to bring together the four community provider organisations across Hampshire and Isle of Wight, which is Solent NHS Trust, Southern Health, the Isle of Wight, and also Sussex Partnership, who provide some CAMs into Hampshire. So that is the premise of what we're trying to achieve. Where we are so far, the strategic case was formally approved by the boards of the four provider trusts, and it is also supported by the ICB and NHS England. The next milestone we have is to take the full business case to the trust boards in October. But in the meantime, we're doing quite a lot of work to agree what the new organisation will look like, recognising a lot of comments I've heard here today. Place remains really important to us. Whilst it will be one organisation, we're really keen that we maintain local delivery and local place. There are some aspects that can be, as Jo said, there are some aspects which can be delivered at scale. We already do that. So dental is a special care dental is delivered across the whole of Hampshire as one entity. Sexual health services are another, but there are some which need to and are really right to remain local. So whilst we want to bring the organisations together and to try and remove some of the unwarranted variation, because there is some things, because they've, as Jo said with the CCGs, things have been commissioned locally and have sort of built up into these organisations. There is an element at times of the same service being delivered slightly differently in each place. So it's about removing some of that so that people get the best service that they can. But this project in its own isn't about changing services. It will give us the platform to then agree and work with our local communities and our partners to see where we can make some of those improvements. And it's about our service user and patient care that we are really working to improve. We are in the middle of a 6-week engagement process with local communities, work really closely with our local authority partners and with the ICB and with our community. So we have a work stream which is really getting into our communities to understand exactly what this would mean for them, what is it that would be of benefit, because it's no point us delivering a new organisation which actually doesn't meet the needs of our population. So that's really critical to us. This is also important to emphasise this is a clinically led piece of work. We have clinical work streams which are led by our clinical directors and other senior clinicians across all of the organisations. Some of the services are already starting to work together. Our children's services have made really good connections across the organisations and are working closely together. There's a number of workshops and other activities to try and make sure that we're listening to our populations, listening to our partners, and also listening to our staff. They're the ones delivering the services, so they know exactly how we could do this differently or better as a merged organisation. But as I said, it's not changing our service delivery. The merger of the organisations actually enables us to think about what we do next to improve it. I don't think of anything else. Oh, just one thing to note, that our the new chair of the organisation has been appointed now. That's Lynn Hunt, who's the chair of Southern at the moment. The CEO appointment process starts next week as well, so that will be the next appointment, and then the executive boards and the rest of the structure will be defined from there. Is there anything I've missed, John?
Just the timeline for completing the merger is April next year, but it's acknowledged that actually that isn't a kind of point in time. Actually, it's a process, and it's going to go on well beyond that in terms of developing services across Solent and Southern and the Isle of Wight, but placing actually the neighbourhoods. Some services are best delivered at a neighbourhood PCN level, and it's trying to make sure that it's clear what services are at what level.
Thank you. Any comments or questions? Helen?
I would just like to say, in support of the presentation that Joe's just given, or the discussion, is that because we all have, and I think Sarah will echo my concerns, we obviously, and Joe, we've got very much integrated services here, which includes integration with Solent. And I think in response to some of our concerns, bearing in mind the conversations we've just had about coming up to one big organisation, that we lose the place integrated working, we've been meeting bi-monthly with the medical director from Southern, who has taken this lead, around children's services and sexual health services, which Joe mentioned. And I think that's been really helpful, both to continually be able to raise our concerns in a open, honest conversation, which is what we've had, and I think Hayden has attended, would say that. But obviously, to keep that conversation going is going to be really important, because people will change. But I think you've heard our concerns and are listening to our concerns. However, I think we're going to have to continue that, because it's all well and good, and I think we're seeing that at the moment in the conversation we had about the ICS. In the run-up to a change, conversation's good. Obviously, it's ensuring that continues then into delivery. And I think we are all dependent on each other, aren't we? Because our services are so integrated. You know, we've got Solent, we've got NHS staff who are managed by council staff, we've got council staff who are managed by NHS staff from Solent, so it's going to be really, really important. And particularly, because I do get the complete point about services being at neighbourhood, but we also have to make sure that we're delivering services together at place, which then includes neighbourhood, and not a one-size-fits-all. But you've been really listening to that, and I think we feel that we are being listened to and that we are part of the conversation.
Thank you. project?
Yes, Project Fusion, or towards a new organisation. Certainly Healthwatch became aware of Project Fusion and raised it with the engagement team at Solent. And a community partners group came, which I think Jo was talking about in her presentation. And there was an opportunity to be a community partners co-chair, so I jumped at the opportunity and chaired last week's meeting, which was fascinating, bringing all the community partners in the region together. So just to share that, but also to completely agree with everything Helen's just said. I have to say it's very important that place, neighbourhoods, PCNs all thought about in the mix, and the conversation must go on beyond next April, which I think your colleague, whose name I didn't quite hear at the beginning, but yeah, I think it's important it doesn't stop come next April.
Thank you. Jo?
Yeah, I'd just like to echo some of those comments. And Alistair was at the HOSP last week, and I know local councillors were also raising concerns and wanting very strongly to continue that integrated approach. And I think, obviously the ICB is working very closely with yourselves and the community mental health, other mental health partners to develop the strategy for Fusion and the kind of the high level commissioning intentions. And I think it's really important that links into the conversations with community partners and the engagement with communities, because I think the rationale behind our integration journey in Portsmouth was very much based on what our residents told us, that they only want to tell their story once. They don't understand why services arrive like buses. You wait for ages for one, then 3 turn up at once, and you're not quite sure which one is the right one. So it's that's driven our journey in Portsmouth, and I think it would be interesting to see if we see those same conversations, same needs coming through, because I think that is really powerful in why we think being that integrated delivery model is so important, and how we can strengthen that through the Fusion journey, really. So I think there's a role for all of us in that, I think that community engagement work is going to be absolutely critical to this as well, so that we get the right strategy and the right model.
Thank you. John?
Yeah, if I just say, the Portsmouth system is really highly regarded because of that integration, and I think people are looking into Portsmouth to see how it's done here, perhaps not fully understanding the amount of work that it's taken to get to that point. And I think it's also reflected in the performance figures in terms of things like discharges from QA, how well Portsmouth's performing in that area. And so I see a lot of my role is about protecting that and making sure that integration is a real priority for Portsmouth Place, and that we level up elsewhere rather than levelling down in Portsmouth.
Thank you. So Matt and then Susie.
Thanks, and thanks for the report. So I requested the report because we hadn't had anything at the Health and Wellbeing Board about Fusion, which is really concerning, actually, bearing in mind it's been going on for quite some time. And obviously, Jo, well, actually both of you, I know you're sort of newer in post, so it's certainly not anything personal there at all. So we had a meeting last year where we had Rod and Andrew from the two health trusts, and they both talked about very strongly about our integration and how it's a paragon and everything, and yet I don't think that the Project Fusion, which of course, though I did hear it mentioned, we can't call a merger, it's something new, but we all know it's a merger. We don't really see the benefits of what benefit it's going to be for Portsmouth compared to what we have now. Actually, I think one of the great strengths about Solent NHS, despite the issues that have been going on in more recent times, is the fact that it is focused on those two urban areas, on Portsmouth and Southampton. And we know that Southern Health has a very checkered history, and the impression, not just of people within the system, but also within the employees at Solent, having worked until last month for a contracted out bit of Solent NHS Trust, when I worked for Remind for Solent Mines, was talking to colleagues there, they just think it's going to be a takeover of Southern Health. So if you've got that impression within the staffing, you've got that impression from outside as well, it is a real concern. And we all know about the financial difficulties that Southern Health have had as well, and it just seems to be, this seems to be a process whereby you can get Portsmouth Southampton disadvantaged for the issues that Southern Health have had over many, many years by becoming one large organisation. So I think that is just a general thing. Is it still hasn't really been. This is a really good presentation. I'll say thank you for the report, but it really doesn't show how this is going to be better. And actually, what we should always be looking for is this is going to be better. You know, the Project Fusion, whatever this new trust is going to be called, if indeed it happens, how that's going to improve things, when we know from everything we get from you is integration is key, integration is important, and we are a paragon. And that's something that's been mentioned. I think the other side of it is, and this does come from my personal experience, is integration isn't just about the City Council and the NHS. It's about our voluntary community and social enterprise sector partners. And they are absolutely key and critical to that. And frankly, in the last year or so, the interaction with the VCSE locally has been pretty rubbish. And there have been decisions made and ways that things have been done which have been pretty awful. And therefore, rebuilding that trust and understanding about, again, if Project Fusion is an opportunity for anything, it's an opportunity to rebuild relationships, because relationships in certain areas become very poor, but we also know we have other relationships in other areas which are extremely strong. So I think that's, so my concern is I still don't see what benefit this is going to be, apart from an administrative convenience for two NHS trusts, becoming one NHS trust. I have the real concerns about the integration side, that it's good words, but how is that going to be implemented and secured into there, not just for Portsmouth's benefit, but for Southampton's, for Hampshire, and for the Isle of Wight as well. How is that going to be strengthened and embedded into that strategy, and isn't just going to be something that can then be, well, we'll just do it for a time being, and then it's just going to become, well, it's just administratively easier just to do everything Hampshire, Isle of Wight wide. So I think that's where I want to be. And you talk about the 6 weeks of engagements. I've just looked through my calendar. I have not had an invite to any meetings specifically for me about Project Fusion. There's nothing there. And that's something that I would have expected that I would have in my diary as a formal meeting request for myself, at least myself and the other political health and wellbeing board chairs, perhaps other members of the administration here and with administrations from elsewhere. I don't know if something from Police and Crime Commissioner, if that's come through at all, to Terry or come through other sources. So I think having something reaching out rather than thinking, well, we're doing this and then expecting people to come in, and that's not great. So, and we know, and just as a last thing, obviously we represent not just the system in terms of our health and wellbeing boards for Portsmouth, but we also represent the employees, a lot of employees of Solent NHS Trust and Southern as well, who live in the city, and they, certainly from my experience, they don't feel particularly engaged. So I'd like to see that more engaged. I know there are ways of getting engaged, but really just having, it's very fatalistic. it's very fatalistic, the attitude of former colleagues. And I would just hope that we just get a better move forward. We're in end of June now. This is supposed to happen by next April. It might be a bit longer. Just the engagement needs to be a lot better.
Thank you. I understand your comments completely, and I won't be able to answer all of them now, but I will certainly make sure that I take it back and we can feed that into our process. Just a couple of things. I've also heard that some people say it's a takeover by Southern. Some of that is a part of the statutory obligations. So the organisation has to be a foundation trust, and of all of us, Southern are the only ones that are a foundation trust. So they have to be the shell of the arrangement. Joe, tell me if I get this slightly wrong. They have to be the shell of the arrangement. So therefore, that's why it is perceived that way. But genuinely, all of the conversations I've been involved in recently have been a genuine desire to make it a new organisation, not rehash an old organisation, genuinely bringing those together to create something new. So that's one thing that does explain, because I know that if you think you're going to be under the Southern barrier, banner, it does make you think that, oh, it's a takeover. But that's one thing. The comms and the engagement, I'll certainly take that back to make sure that we haven't missed anything there. And I will be coming to these meetings in the future so I can make sure I can give an update regularly on that and cover the things that you need covered, certainly. The April 24 date is almost like the start of it. We have all the legal and statutory things we have to do by 1st of April to have one organisation. We'll have a different lanyard. We'll have our payslip will say something different. But the work really starts there. All the stuff we're doing is preparatory work to get us to that point. But that isn't where it stops. It's not like that's the end of it. That's really where we can really start to see some benefits and make a difference. So hopefully we'll be able to communicate that more effectively as we move forward over these months. But the work of what the new organisation looks like is ongoing right as we speak, and we spent a day out on Friday going through it with our senior leaders across all of the organisations to really try and make sure that we are getting the feedback and input from every level of our organisations, and certainly making sure that we are getting that from everyone who may not have that same opportunity that I may have to input to that is really important, because the staff engagement is really key, because they're the people that are actually delivering these services. So absolutely understand your comments there, but I will take back the ones that I can't answer right now, but to make sure that we pick it up.
So John, yeah.
And I think it's a good question about actually what the benefits are. And the reason I took on this role 6 months or so ago was a lot of it was because of that fusion, because it gives us the power from community services to have a stronger conversation with the ICB about resources coming out to the community, supporting people at home, and making sure that patient voice is heard louder. I think it's difficult as segregated organisations always to get that attention, and I think as one organisation we hold more power there. And as an example, it's about that strength for two-way communications. Building virtual wards needs to be different in Portsmouth compared to how it is in Hampshire, and the one-size-fits-all model doesn't work, and it's about feeding back to the ICB that actually there is variation, and we don't want unwarranted variation, but there's lots of variation that's very warranted, and to support that.
Thank you, and thank you for waiting. Susie, your turn.
I hope this doesn't come across as too simple and stupid, but this links to the previous agenda item as well, is it feels to me like we're dealing with what we were fearing around the loss of opportunities around place. And so when it came to this item and I look at that, and you think of some of the strengths that we have in the city, which have been based on, as it were, the old model, and of course you think you don't want to lose those, you don't want them to be diluted, or for this one-size-fits-all thing to happen. And I know this is a kind of strategic level, but can this is the stupid bit. Can you give me an example of something, for example, neurodiversity, or something that we feel that in Portsmouth that we have been recognised and there's been feedback about us leading the way, as Sarah's come up with some examples. How in this model would that be protected from a strategic point of view? Because I get the logic, but there's nothing in there that allays my fears around the discussions we've been having around place.
I think it is a concern that the services that we do well in Solent, that we do well in Portsmouth, we need to protect those and make sure that there isn't a downgrading of those. I think Solent also provides lots of services on a wider basis, and there is for example, if I give you the example of Parkinson's disease, because it's in my area of knowledge, we have, I think, 1 or 2 Parkinson's nurses to cover Portsmouth, and actually there isn't a resilience there. So if one is off ill or one retires, then actually having that wide resource across Hampshire gives a bit more resilience to those smaller services. The larger services, such as community nursing, actually are going to be place-based, if not neighbourhood-based, because it depends on the scope of the work, really. And that would be the same as neurodiversity. Actually, although it's something that we do well in Portsmouth, we can still learn from other areas, and I think that's the other thing, is widening that scope means that you can learn from what's happening elsewhere in the patch.
Jo and then Roger.
Yeah, thank you. And I think Susie as well, and Matt, because I really do understand the concerns, but just to try and understand, the purpose of this, I think we have to be realistic, don't we, in Portsmouth, and the challenges that we face and the increasing demands that we're seeing on our services means they are becoming less resilient than they have been in the past, and we see that particularly around mental health and our workforce challenges in across the board, medical, dentistry, nursing. So the aim of Fusion is to provide that resilience to those NHS professional services and those statutory services to create resilience in the psychiatry workforce, and then to move together around to develop what is best. But I do think the community engagement is so key in this, to hear what people are saying, because I think what they will still be saying in Portsmouth, and perhaps more so in other areas, is that services don't work in the way that best meets their needs. They're still too hard to access. They're still not joined up enough. And I think it's really important that we play that in, because it's really powerful in how we make the change. And it's not something we're all very good at. So I do think we can learn with our local authority colleagues. The other bit I think we need to say, and again, the role of the ICB in this is around how does this play in with all of the other strategic priorities. So Fusion and the new organisation has to deliver in line with the ICB and the ICS and the ICP partnership strategic priorities, and things like the Fuller report. So, how we integrate community nursing with social care, with primary care is really key, and that has to happen at place. And I think that's the bit we need to see more come out of Fusion around it's the how, isn't it? How will we do this? How will we achieve and strengthen integration, not just in Portsmouth, but across the board? So I think we need to support you in that and link that in. And I don't think between us, the ICB and the Fusion work is getting to where we absolutely need it to be. And I think there's a role for all of us to play in that and to help with that. So really happy to take that back and with colleagues and think about how we can do that, so we get those messages much clearer for our partners.
Thank you. Roger.
Thanks, Linda. I have to agree with everything that Matt said, and Susie, and nice to hear what Jo's just said. Healthwatch has a regular regional Healthwatch meeting with the Hampshire, Isle of Wight and Southampton Healthwatches, and we had a meeting, I think earlier this year, end of last year, with the engagement lead from Solent, and spoke about Project Fusion because we'd heard about it and fought really hard to get involved and to become a community partner, which I spoke about earlier, but it did seem a bit of a battle with people not really knowing what was happening, the engagement team, which was a shame. We've heard that the Fusion Operational Group, or a name very similar, has asked 4 particular questions of the community partners, one of which I know is, what would you like the name of the new organisation to be, which doesn't seem a great priority. We had a regular meeting with PHU, with Penny and Liz, who hadn't been invited to join any work with Fusion as they provide mental health services at QA, so that was interesting. So we networked them towards Fusion. The regional health watchers are quite concerned that initially in some ongoing organisationally led groups are not very patient focused, they're very clinically focused. And we've continually asked questions about place, which I know previous speakers have mentioned, about the provision of specific services like mental health services, because there's been a lot of work locally on provision of mental health services and patient care and involvement. I'm not really clear whether that will be, as John was saying, whether it will be place specific. So just wanted to make those few comments, Linda. Thank you.
Joe?
Yeah, I think, you know, and to support Solent colleagues and the whole Fusion team, I think you've articulated, Roger, where collectively and with the ICB support, we perhaps haven't got that wider engagement quite right yet. And I think the rationale for that is, and to be fair to colleagues, there's a huge job of work to do to create the organisation and to support the staff into that. And it's almost, that's the pre-bit, and that's what I think you say, that's some of the work you're doing now. There won't be changes until April. So I think we do need to give colleagues some support, but also to support you and wider in how we do this wider communication, so that we are all clearer on the benefits of this, both for your staff, but also for our wider communities as well. So, Joe, I was just going to email you to say I've asked Hayley to link in around some of the community events, particularly for Portsmouth, because I think we're really keen on how our local community voice is heard. But again, really happy to take that to ICB colleagues that I know are supporting, about how can we, make that more visible and get support you with the narrative and the messaging around some of this, so it's easier to go out and we're all saying the same things, if that'd be helpful.
Thank you. Because I think that was a really useful discussion, and I think we're all really keen to hear as things progress. So if we could have it as a regular kind of update, that would be really helpful. Thank you. Better Care Fund, Joe.
Sorry. This is unusual in the fact that we're actually able to bring it to a Health and Wellbeing Board before submission date to NHS England. Usually the timing is wrong and we get it afterwards. So, and even better, we've managed to provide you with the update from last year as well, so you can see it properly for this time. I guess there's very little change at the moment. It is still a draft, but we've been working on it very much together. I guess it's important to note that with the financial challenges, some of this may change, but our focus very much through the BCF schemes in the specification, as part of the overall Section 75, is about how we support that admission avoidance and discharge to assess. And as it's been mentioned, we've seen some really good results in that locally. We had a blip last year, sort of last summer in October. And through the winter, but we've actually recovered really well and got quite, we're really seeing the benefits of the integrated Jubilee working. And so it's those sorts of things that sit underneath the BCF and the work that we're doing with Hive and the Red Cross and the Salvation Army around that, how we integrate the VCS more into that space and working with PRRT and the Jubilee and Spinnaker teams. So it's fairly familiar, I think. I think we're all really sighted on our joint priorities around this, but we are having to look. We do it every year and at every meeting, but really looking intensively with even more scrutiny around, are we getting best value for everything that we spend through the BCF? So that may mean there'll be some changes to services in year, but the priority for us is getting that D2A pathway right and making sure that we're getting more people going straight home, or that if they do have to go into Jubilee or Spinnaker or a short placement in a care home, that we are moving them through that journey in as timely a way as possible.
Thank you. Has anyone got any comments or questions? Oh, Roger.
Isn't Jubilee closed?
Yes. So the original Jubilee house, yes, it did close, but part of that was we like to confuse ourselves really, because we moved Jubilee and Victory into what we then called the South Sea unit in Harry Sotnick House, and then we renamed it Jubilee. And that was really a CQC reason, wasn't it, predominantly? But also it felt like the right name still for that unit, but it did cause us a little bit of confusion initially. Matt?
Yeah, I'd just like to support, as Joe said, just about the D2A. I think it's just worth saying as well, just about BCF, that it's yet again another area where we've got financial pressures incoming, and we're it's where we're not getting the money from central governments that we really need to keep up with inflation and costs and all that kind of stuff. So it's one of those areas that's because we all know how getting D2A right improves things massively. It helps everything. It helps people have more resilience. It helps keep them better for longer. Helps them live the lives they want to live. And obviously, and this is the thing, is why it often is done the wrong way round, but it's all of those things, and it helps get people out of hospital in a timely fashion. And we have, and this is actually a great story of integration, because the way that we work on D2A in this city is one of our real success stories, and something that we've worked on for years to get it right. We've got Simon, who has his joint appointment between who's here at the back of the room, joint appointment between the council and so NHS, and with the work that he does with that integrated team on discharges is brilliant. Just to say, on the name of the units, there is a desire to rename it at some point, and on a theme of Sherlock Holmes. So it's something that we talked about before the Jubilee unit merged in and everything. But it's something that I was talking to the leader yesterday about. So I think he's working, but we want to work with the staff to come up with a name. But it's part of the work that the city's doing to. We have a lot of Sherlock Holmes heritage in the city, and we've now got a Mycroft Terrace, I believe, and we're looking for opportunities to name things after Sherlock Holmes or Arthur Conan Doyle stuff. So, any ideas? Maybe Reichenbach House? I don't know. Baskerville Hall? You know, it's yeah. Any ideas? Let us know, and we can feed that in for the staff.
Thank you. I don't know, Joe, did you want to come back on any of that?
I think I'll leave it to our staff and perhaps the patients to come up with a really good name. And then Jubilee at the moment, and it was apt because it was moved in the Queen's Jubilee year, so that's why we kept the name as well for a while. Just on that point, Matt, thank you. I think, you know, I think D2A is a real success story for us and the Jubilee unit, or whatever it becomes in the future, is a real success of that integrated partnership. I think, again, it's important that we also recognise we've still got further to go in our admission avoidance piece as well, and how do we turn people around more quickly. So that is a lot of the focus of where the team and Simon and Joe and the team are all doing the work this year as well.
Thank you. So we're actually asked to ratify the submitted Better Care Fund end of year return. Are we happy to do that? Yeah. We are requested to approve the draft Better Care Fund narrative before submission. Yeah. And to approve the draft Better Care Fund planning template. Lovely. Thank you very much. Pharmaceutical needs assessment next. Helen.
Thank you, Chair. I'm going to try and keep this mainly short, but also more importantly simple, because I have to be honest, this has been a very complicated process. But as you know, we as a Health and Wellbeing Board have a responsibility to publish a pharmaceutical needs assessment, and we did so and produced the current one, which was published in October 22 and runs until 2025. However, as you also know, there is a lot of strong feeling about community pharmacies and the risk to current increasing closures in line with our other concerns around access to primary care and dentists. So we have so in February, and I think this has been on the agenda for the last 2 or 3 meetings actually, due to that strength of feeling. In February 2023 at the board, we agreed to consult on a revised P&A, and that was in light of a number of closures, particularly a consolidation and closure around the Elm Road. So this paper, and I'm going to assume that you have read it, it does cover the consultation process that we had to go through in light of reproducing a new or an updated P&A. Feedback, as well as some options for recommendations. Now, it might be a surprise to some that the recommendation, we are making 2 options, A and B. A is to continue to publish the current renewed P&A, but you might be surprised that option B is our preferred or our recommendation, because several things have changed since the meeting in February, including some of the legislative changes. I'm sorry, this is very dry, which mean that we can now do what we intended to do within the existing P&A. That, in light of some of the consultation responses, which were quite serious, mean that is why we've got the recommendation B. So I'll quickly go through a couple of things that are really important on that, if that's okay. So we are coming, basically asking you to reconsider, and for us not to publish a new P&A, basically because, and I'll go through them, we're asking you to, so option B recommended is to recognise the issues and strength of feeling in responses. So I'll just give you an example of a couple of that, of the responses that we got, just as an example. Just as an example, God, I've got to find it. I'm going through different bits of my paper now. I can't find the exact bit. This is the trouble when you've got too many bits of paper in front of you. But in essence, we can still do what we want to do for the existing, and the strength of feeling was, particularly from the local pharmaceutical committee, that if we went forward with the current suggested rewritten P&A, we would be basically breaking the code of what is expected in a P&A, so we'd be going against some of the legislative reasons for actually doing a P&A in the first place. Hopefully you've had a chance to read the paper. And I think we put ourselves at risk, both from possibly members of local pharmaceutical committee, but also would put ourselves at risk both legally and financially, of being challenged, because we're now breaking, what we're suggesting might actually break the rules for actually producing a P&A in the first place. I know it's really, really complicated, because we are all trying to do the right thing, which is to try to protect the current pharmacies that we've got in a very difficult financial time of cost of living. You know, all of the same pressures on from cost of living in terms of costs of energy, rent, etc., on those pharmacies, but also the increasing risk of not being able to employ qualified staff, or huge pressure. So we were trying to protect pharmacies, but by doing so we were then putting ourselves at risk of being challenged by pharmacies, in essence. So what we're putting ahead of you is a recommendation to go with B, which is that we don't publish a new pharmaceutical recommendation. We P&A, we keep to the existing. But we then, if we keep to the existing, I've got two further questions. So that's the first recommendation. If we keep to the existing, we are also asking whether we need to provide a supplementary statement in relation to the closure of the Lloyds and Sainsbury's on Fitzherbert Road. We're suggesting that we don't need to do that because it's not that busy and doesn't have a natural residential community, so we don't think it identifies a gap. So that's recommendation to go for option B. Within that we don't need to do a further supplementary statement. And one of the key issues of people's strength of feeling was about the 100 hours at Drayton Community Pharmacy. So the regulations have now changed, and which mean 100-hour pharmacies can drop to 72 hours, and this is one of the key bits of what we would get challenged on. So the Drayton Prime Pharmacy has updated its supplementary hours to provide service for 68 hours, and is currently also, so that would be services evenings of Monday to Friday and opening on Saturday and Sunday within those 68 hours. And they are also talking, which Joe is aware of, to the ICS and Local Pharmaceutical Committee about being able to secure further hours. So therefore we wouldn't have a gap of the 100 hours pharmacy, or equivalently opening now. And anyway, that has changed, so we can't actually raise that as a gap anymore. So the proposal, just to finally get this, sorry, because it's really, really complex. The actual closure of Elm Grove, which was the area that people were most concerned about, is really already covered in the amended, that was covered in the amended P&A to include updates supplementary hours for Drayton Prime, provides an updated map, so we've got to do an updated map and continue to work with primary care commissioners and pharmacies to secure further services we need for our community. So what we're saying, sorry, I know it's really complicated, is if we go forward with option A, we are putting ourselves at financial risk, but we're also biting ourselves in the face to a certain, or cutting off our nose to spite our face, because actually that will then create bad relations with the LPC, who we want to work with to be able to support community pharmacies, A, managing to continue in business, and B, where we do have gaps, identifying those gaps and being able to fill those gaps. Sorry, that was complicated. I've had to go through it about 10 times myself. So, recommendation, option B, and then within option B, that we do further work. We don't do a supplementary for the Sainsbury's on Fitzherbert Road, but we do continue with all of the other things that we wanted to do, including obviously redo the map, etc. And I know this is in the news today, just an example, because I know that Boots have just announced, which I think that could impact on us, another closures across the country.
Okay, I think there's a few people who want to come in. So if we start with David.
Well, personally, I'd be very happy to support the recommendations as I understand them. But I think that's great. I mean, one of the reasons why this has been an issue at this board so regularly is I think it's a really good example of the old adage about all politics is local. Yeah. And I think some of what we're witnessing are changes in the market, changes in the way in which the contracts, or the implications then on how the contracts operate, We know that the pharmacy that does most business for Portsmouth is in Leeds, you know, our local pharmacy. So there have been huge shifts in terms of how behaviours have changed, as they have with all retail. But you know, ironically, at the same time, we've been desperately trying to increase the range of services and the value of the advice that can come from pharmacies. And it was classic, wasn't it? About 3 weeks ago, there were 2 news items on the BBC at the same time. One was about how the pharmacies were going to help the GPs, and the other was about the closure of the pharmacies. So whilst I think it is really important that we hear the views of people on this issue as it impacts locally, I think it's also important that this board thinks about stretching its wings a bit and maybe making some recommendations either to the ICB or direct to the department about the need to be reviewing the way in which this market is structured, because we're operating it as a market, but we're asking it to perform public good. And getting that balance right is always difficult, as we're seeing in so many areas at the moment. I mean, water industry was another big issue, wasn't it, today? So I think that maybe the board should think about making a recommendation either for a discussion and deliberation at the ICB and some recommendations from the ICB up the chain, or it could be an issue for the ICP. But I think it's important that somehow the voice of local people gets into this debate, because at the moment we've got all sorts of bits of technical activity that are having unintended consequences on the ability of local people to receive the advice and the access to pharmaceutical services that they need. Thank you.
Thank you. Matt and then Lewis.
Thanks. Yeah, this has been a saga, not helped by government legislation landing at the wrong time. So, as you see in the reports, the problem we had with the Elm Grove situation was the fact that it came after we'd wanted to go forward with the pharmaceutical needs assessments, but before it actually came into place, and therefore it became a retrospective thing, which is why we then looked at doing this amended version, which would then retrospectively say we had a gap and you can't have a gap. And now, obviously, we've had the feedback there, which is effectively we've opened ourselves up to a potential legal challenge on this, which would be unfortunate. And of course, that has already closed. Added to that, we have this situation with Drayton, where if we said there's a gap there, then the place that is now moved to doing more of a more hours at this site would potentially say, well, you're creating a opposition for us by saying there's a gap. You're saying that another pharmacist can come in and therefore we won't do our extra hours, which you can completely understand their point of view. As Helen said, we have the situation where the Sainsbury's pharmacy is not in it has a small community around it, but not very big, and was not a very well used pharmacy. And if that puts any pressure on us not having an out of hours pharmacy, then that seems to be a perverse thing to do. However, we do know our last year's pharmaceutical needs assessment works, because as you see in 5.2, where it mentions about the conclusions of the 2022 P&A have already been used by the Health and Wellbeing Board to oppose the consolidation application by Rollins Pharmacy in February 2023. It came to myself and Linda as in our delegated authority as co-chairs to close the site on London Road and consolidate into the site 92 Kingston Crescent, which we know has been refused. So we were able to refuse that on the basis of our 2022 pharmaceutical needs assessment. So we know it works, and it was seen as being a valid objection, and that was stopped. That merger and closure was stopped. in terms of saying that, so the gap was there, so if they wanted to pull out, then you've got someone else there instead. So we know the system works. We open ourselves to legal challenge if we don't go for recommendation B, and we also have that risk of creating a situation where we might put at risk our out-of-hours pharmacy. But I think this work has been really helpful, regardless of the fact that the recommendation, which I support, is not to have a new pharmaceutical needs assessment now, and we stick with the one we did in 2022, because what it's done is it has flushed out, A, that we understand our market a bit better now, we understand what their particular concerns are, B, that we know they want to work with us in a positive and constructive way, and I completely agree with what David said as well about us taking this up the line, because I think what we've got here is obviously being mirrored, and we know it's being mirrored right across the integrated care boards, and it's something that we need to, sort of the integrated care system, and it's something that we know we need to sort of get up and as David said, you're saying pharmacists are supposed to do more, and then the pharmacists are closing. So, but if we can use our model here to support a model elsewhere and say you can stand up for this, you can say there's a gap when something closes, and you can stop those kind of mergers, it's a really positive point. So I support option B, and I do not think we need to do a supplementary statement either, because that could put at risk our out of hours in Drayton, and it's just unfortunate, I think, looking back, that we had this gap between our decision being made and it actually being formally accepted and implemented, came in the periods where the Elm Grove pharmacy closed, it's really frustrating, but we were caught within a rock and a hard place, really. So I support recommendation B, and the fact we don't need to do a supplementary statement, and I propose that formally.
Thank you. Lewis?
Thank you. Matt's kind of already highlighted the point, but it was just to pick up on actually the good news story that we've got here, that this plan enabled us to keep the pharmacy in Hilsey, and actually residents have now still able to access that local support that we've kind of all been banging on the table for this morning. So we've got something that works, that's happy to again support the one that works and go with it.
Thank you. James?
Yeah, thank you. I just wanted to commend the report, because I thought it was very well written, and certainly for me with limited knowledge helped me navigate what is clearly a very complex area. And I would support option B. My only question is, how do we intend to communicate that, given the deal of press interest, etc. in this area? How are we going to communicate this decision to pharmacies and the communities?
If you look at the response that we got to the consultation, we actually only got 9 responses. It didn't go out as a consultation to the wider public. It really went to professionals in the field, so the LPC, pharmacies, and obviously the commissioners, who are nationally or regionally based at the moment, but that's moving now down to local ICB. So I don't think that, and obviously this paper will be in the public papers, which are open. I think it's more of a question of we can make a decision about a communication strategy, but I don't think people are actually widely aware. That might not be the answer you were looking for, but I think we can possibly look at it as an opportunity to think about how we want to communicate, how we want to work to protect the community pharmacies moving forward, in the same way that we have done a lot of comms work, communications around the same pieces of work that we're doing around NHS dentistry access, and also to protect primary care. So I think we can again work with Health Watch, work with our comms, and think about how we do want to communicate that positive message that that we have raised now. Yeah.
Thanks, Helen. And I think one of the things as well that I think is really important about this, and Lewis has touched on this in terms of, and as David said, all politics is local. But I think this is one of the things where I think for us as councillors to take the lead on it. And so I think the communication we need to make. I know that a lot of councillors are aware, but a lot aren't as well. So, but to really make them aware that this is in place. And if they get any wind in their wards that pharmacies are looking to close or anything like that, that we have this that we can then use. So we can use the success of Hilsea to say this does work, raise that with, bring that to our attention in terms of the from the public health side, because it sits under us, and then we can put that in train to make sure that's then flagged up, said this is a pharmacy, they want to close it. Member says, well, obviously that's going to have an impact, and then and we can then do exactly what we did in Hilsea and go, this is going to create a gap, that's unacceptable, and we can approach the closure. So I think it's a really big part of this, James, is that we need to make it available to all the people in general terms, but we also need to make sure that councillors know it's a tool that can be used, because we like tools to use, and where we know it works, we know it's a really successful tool, then it can be something that we can make use of right around the city, because this is going to happen again. Let's be under no illusions about that. This will happen again, and so we need to make sure we can use that tool as well as possible.
Thank you, Joe.
Yeah, thank you. I mean, really supportive of option B, as colleagues have outlined. But just to come back on some of the points around, the ICB does now, or all ICBs do now have delegated commissioning responsibility for community pharmacy, although obviously that is within a national contract that is set, and there are a number of challenges within that. So I think David's point about how do we raise this is really key. One of our responsibilities, and we're in the very early stages, is developing a community pharmacy strategy. So I think it's really important that we are, as an ICB, communicating and engaging on the development of that strategy with all of our places, our health and wellbeing boards, but also the ICP partnership, which might provide a bit of a platform for some of that discussion as well. So just wanted to add that.
Thank you. And so can we just be clear then? We've got to choose whether we're having option B or A. From what I've heard, it looks like we're happy to go with option B, which is what was recommended. Can I just clarify whether we wanted to do a supplementary? Because in here it says it's proposed that we would, or we didn't want to.
No, that we didn't want
You
to.
don't want to.
Yeah. As the point that Councillor Winston, because
Yeah, that's why I just want to check.
Extended hours at risk.
Because in 5.4 it says it's proposed that it is issued, so it made me think that you wanted us to approve that, but you don't. You don't want a supplementary issue necessarily. No. Fine. Is everyone happy with that?
Can I just... Well, I suggested that we also made representations to the ICB, and maybe we copy the other health and wellbeing boards into that, because I suspect it's a burning issue.
Yeah. So on that point, we're going to go via the ICB route and speak to the other health and wellbeing boards and go that route in. Lovely. Can we put that on as a recommendation as well then, please? Thank you. And now I'd like to welcome Lisa Wills from the Community Safety Plan Update. She's the Strategy and Partnership Manager, so she's going to come and do that for us.
Hello, everybody. Wow. There's some new faces around the table. So I just wanted to start with, so we're on the same page. So for those of you who are not aware, the Health and Wellbeing Board took on the statutory duties of the Community Safety Partnership in 2019. And one of those statutory duties is to do the strategic assessment and produce a plan based on the priorities identified in the assessment, and then to put in place actions to address them. So this report that has come to you is a progress report on that plan, the existing plan. And overall, there's been consistent and good progress, but we do have some long-term challenges, as lots of cities do. Just to also to make the point that these are really long-term strategic priorities, and they underline and drive the issues in the city. But they're supported by a whole range of operational activity, hence the length of the report, actually. I'm sorry it was very long, but there's a lot of stuff going on. But the focus on these priorities is over and above the delivery of those day-to-day services by police and probation and other colleagues. The drivers for crime and substance misuse and offending are complex and complicated. And so detailed, consistent analysis is really important. And that work is done by our public health team. And I work very closely with Matt Gummerson, who's our head of public health intelligence. The report explains that priorities haven't changed significantly since last year and have therefore been rolled forward. It's also important to explain that community safety activity is fully mainstreamed across the council in Portsmouth now. So work to address the priorities that we've identified is delivered under a range of other related strategies and plans. And because we're keen to reduce duplication and maximise that collaboration and coordination piece, this report pulls together activity that's going on across other areas. So I have also to thank my colleagues, Alan and Caroline, who's coming on next, I think, and others. I put it in the report because the work is the report is based on their work essentially. In 2.3, we're asking the board to note that the findings from the full strategic assessment, the 3-year one, which will be produced and brought here in November next year, that will be used to develop a new community safety plan alongside the other related plans. If you look at item 10, you'll see there's a whole list of plans and strategies there that we use to deliver against these priorities. So just really, really briefly, I'm just going to run through priority A, which is reducing violence, including serious violence and knife crime. We've got a new style VRU hosted by the Police and Crime Commissioner, and the funding's been centralised and the activity's been centralised. And then that includes funding to support the new serious violence duty, which Helen's going to be leading on for us, and I'm going to be supporting her with Matt. Serious violence has remained relatively stable in Portsmouth, but there has been an increase in demand relating to domestic abuse, including increases in the number of repeat perpetrators, which is of concern. And that's one of those tricky long-term things that we still struggle with in Portsmouth, and I'm sure across the country. I don't think we're unusual in that way. But we have had some really positive feedback from the clients that are using our support services, domestic abuse support services, and there's some quotes there in the report which have come from a survey that we do with people ongoing, day to day. We do that. We don't do it as a one-off. It's a long-term thing that we do all the time, and we use that information to improve the services and change them if we need to. So despite these good services, there have been 3 further domestic homicides since 2019. They're all very different. It's really interesting and important to note that they are all very different. But we need to do some more work over the next 12 months to identify whether there is anything that we can identify that's driving that increase, or if it's simply a coincidental increase as a result of, because Portsmouth hadn't had any domestic homicides until between 2004 and 2019. So I'm not quite sure what it is that's driving that. So priority B, which is tackling drug-related harm, increasing access to treatment and closer working across physical and mental health care, now led by our new Combating Drugs Partnership, chaired by Helen, supported by Alan Noble. Lots of work gone on over the last 12 months to produce a really comprehensive needs assessment, again by the public health team, and to develop a new plan with 3 key priorities, which is based on those findings. Very similar process to the process that we've gone through around community safety for many years. And there have been increases in the number of people in treatment, which is great, but the young people services need further investment and focus. So priority C, there's masses of work going on around priority C across children's services, as Sarah will tell you, in early help, multi-agency teams, family hubs, school link coordinators we were talking about yesterday, doing a fabulous job, and of course the youth offending team. And that section of the report is lifted totally from the Youth Justice Plan, so thanks to Lisa Morgan for that. So just finally, I wanted to draw your attention to item 9, which are some national developments, which include a review of community safety partnerships, which is being driven, I understand, by the National PCC Association. Hopefully, I am going to be involved in the groups, the Home Office groups that are looking at that. They're just analysing the responses to the consultation now. And then to item 10, which is the plan to develop the new community safety plan for 2025, and that just sets out what the plans are. So I hope that's all clear. Happy to answer any questions.
Thank you, and thank you for the report. Any questions or comments? Terry?
Probably comments, really, if that's okay, and it's probably a good opportunity just to come in and mention a few things that are happening from the OPCC. I'll leave the VORG and domestic abuse stuff to the next item agenda, if that's okay, because it will be covered there, I'm sure. But just to reassure you all around the police's capability to deliver some of these, to work in partnership and deliver some of these priorities there. Of course, we're in a position at the moment where there are the largest number of police officers on record nationally. Hampshire's percentage of the 20,000 uplift was 498, and as an office we pledged 600. We've actually gone further than that, so we've got a net gain of 635 odd officers, able to support and deliver some of these priorities. The second thing I think is worth noting is the new geographical model recently announced by the Chief, which is an investment into neighbourhoods policing. We've got to put these 635 officers somewhere, but a new geographical model that really looks at neighbourhoods policing and communities with named officers, with area cars and various other things that really resonate with our public. And on that, you'll also have area commanders that have response and patrol and various things that they need, it's tools that they need to go out and deliver that. The third is probably removal of PEQF, and I'll mention that very, very quickly, which is the police entry, mandatory entry degree, which was something that was stalling new recruits from getting out and doing the job. It was a 3-year degree, often about essays about things that may not necessarily be about operational policing. Which has, we in Hampshire and the Isle of Wight were the first to remove that with a new model called Policing Plus, which is a bit more of a direct entry into operational policing, and we're doing some work with armed forces and direct entry there. I think probably the thing really worth mentioning, it may need to come back in future meetings as an item agenda, but it kind of covers 6.11 and 6.12, and that's that mental health part around community safety and particularly policing, and I think it's probably worth just saying a few words in response to the Met's announcement about pulling away from mental health calls and what have you. So this comes on the back of Right Care, Right Person, it's called, and it's on the back of the Met's announcement to scale back on their mental health resource, and it started with the Home Secretary last year asking for a review into the unwarranted mental health demand faced by policing. And the review identified a model called the Humberside model, from Humberside, called Right Care, Right Person, which was then presented to PCCs in February, and an agreement was made to work on a national partnership agreement to look at using Right Care, Right Person as the best practice to, fundamentally we need police officers to do the job that only police officers can do, and not pick up all of the slack for mental health and what have you. Following that, we were asked to consider our response to it. The National Partnership Agreement was being drafted by the Association of Police and Crime Commissioners, the National Police Chiefs Council, Home Office, and Health, and we were waiting to see what that national partnership model looked like in order to be able to kind of roll that out and what have you. It's fair to say that the Met probably jumped the gun a little bit, really, and went straight away with it and started making an announcement, which has probably left a little bit of a divide between police and NHS. But there is a national SPOC that's on on hand to deal with that transition. So in Hampshire, and this is the important bit I think, in Hampshire and the Isle of Wight, I'm pleased to say that we've been implementing this for the best part of 3 or 4 years with a model called Street to Suite, and we've tried to make sure the force have made sure there's not a vacuum left behind by any announcements and what have you. So the force in Hampshire and the Isle of Wight absolutely are dedicated to making sure they protect people and look after people. And there are some, of course, police shouldn't be the prime response to mental health, but there are some situations where, of course, police will continue to attend. So where there's criminality, for instance, where there's a police-only power needed, like a Section 135, where there's life at risk, where somebody is missing, although I think there probably needs to be a little bit of pushback on some areas. If you've got a child, for instance, which is under the care of social services and running away every week to Scotland to be with family and friends and what have you, is it right for police to be kind of spending shifts returning that child? I don't know. There's some work there to kind of look at who owns that, I think. And of course, where there's violence and aggression that's beyond the ability of hospitals and health providers to manage. But over the last 4 years, the force have looked at this Section 136, and that is something that gives police emergency powers to take someone from a public place to a place of safety, and they do that through a number of things. So we've got mental health ambulances, so designated vehicles that can attend and deal with the provisions on site there, which is really, really helpful. There's rapid response vehicles that are there to kind of attend scenes and give various advice to the police or the other services there, maybe health or fire. We've got mental health assessment transport, which are unmarked people carrier type vehicles, which can take various people from one place to another sensibly and without subtly, I guess, without having a police officer dressed in uniform with branding all over the vans. And there's various other things that we do in terms of making sure there's mental health support in 101, community cafes, so that situations can be de-escalated in communities. But the relationship between health and the police is a strong one, that they've worked together for the best part of 4 years, looking at crisis alternatives, triaging in 111. And I don't want the board to feel that there's a hard stop from Hampshire Constabulary around mental health. It's it's fair to say that we've been doing this for a long time. We probably haven't shouted about it as much as we should have done, or the force should have done, but that's because they're waiting for a national model and what have you. But Hampshire is in a very good place in terms of its relationship between frontline officers and mental health services.
Thank you. I think that's a really useful update, and I think that's why it's so important that you are fully involved in Project Fusion, so that moving forward you can make sure those are strengthened and not lost. Sarah.
Yeah, I just want to say thank you. I think it's a really strong report, and I think it's a really informative report reflecting the work done across different parts of the city and across the City Council and partners beyond. I just want to voice concern around the short-term funding of some of the pieces of work that we do in the city and the vulnerability of that work, and again a reflection back for some of this place-based work to really be an important continued funding stream. I think we have seen some of that place-based funding in respect to the VRU taken back centrally, and we do have concerns around the impact of that in terms of our operational reach within the city. We are heading into we're in the summer. We know in the summer we hear an awful lot of negative reporting back about our young people in the city and concerns about groups of young people, and we have to ensure that we are resourcing in terms of community outreach for those young people and making sure we are targeting them correctly. We have some amazing services in the city, are kind of reaching out to the kind of partnerships around our young people. But we keep needing to do more, and I think we need to ensure that it is appropriately resourced and it's recognised the different pressures within the city and the border counties around us. I also want to reflect on the work that's being done across partnerships in respect of the integrated missing trafficked partnership done with young people, health and police, that's working really effectively to target some of those young people who we know cause us all an awful lot of time and resource, but actually they are our most vulnerable, and they are most vulnerable in terms of criminal activity, but in terms of exploitation as well. So I want to reflect that back into this meeting as well, that the city is doing some great work and leading in that work at the moment.
Thank you. Lisa?
Just to say that some of the work that we're doing down at the Hot Walls this summer is being funded by the Police and Crime Commissioner, which we're very grateful for. I think we're just looking at a press release at the moment to do that. But also was offered more yesterday by Sorrel Kenny, so I'm going to go and talk to her.
We always like offers of more. Lovely. Well, thank you for that. So we're asked to note this report, and obviously we'll look forward to hearing more about the emerging priorities when we find them out. Thank you very much. And we're moving on to the domestic violence strategy, and then we're going to invite Caroline to join us.
Good morning. Thank you for having me here. This is not the domestic violence strategy. This is the violence against women and girls strategy proposal. And it's important to say that because I was going to say it a little bit later on, but often when we talk about violence against women and girls, we're really talking about domestic abuse. And actually, violence against women and girls is a spectrum of behaviours. It is the cultural norms that create a space for violence. It is sexual crime in public places. It is more niche activity, including honour-based violence, revenge porn and upskirting. So it is a spectrum, and it's understandable that our minds go to domestic abuse because you'll be aware from Lisa's report that it is one of the largest drivers of violent crime reported by police in the city. It is something that we've done a lot of work on for some time. But in recent years, high-profile cases and moves nationally through the National Expectation Statement are inviting us to look more broadly at violence against women and girls and to come up with more comprehensive response in partnership together. So you'll be aware that we came to the board together, myself and Paul Markham, to present a paper in November of last year that said that what we would like to do is to look at what our local response is in Portsmouth and to see what we can do better together to maximise that. So following on from that report, we have worked together to review and explore local plans, and we're also connected regionally to the work of the Police Crime Commissioner's Vaughan Task Force. And what I brought back today is a short summary paper just seeking your approval to progress towards the development of a violence against women and girls strategy for the city in partnership, of which, when we've done that work, we'll bring it back to this board to ratify. We've been to the domestic abuse strategy group yesterday and had that discussion there. They welcomed this. They can see how there are a number of opportunities that it presents. There are obviously risks that we need to be live to, like the dilution of some areas, or perhaps an agenda that could seem to not recognise the experience of all people who have experienced gender-based violence. And I need to be clear in that when we talk about violence against women and girls, we are talking about all victims of these crimes. And at some point we might need to find a way that we communicate that more effectively to make sure that no member of our community feels that this is not about them. But that broadly what we want to do is to have a task and finish group that comes together with key stakeholders to develop, co-produce this strategy. We expect it to have pillars that are the usual suspects, so it's going to have domestic abuse, it's going to have sexual crime, it's going to have some new faces in it. It's going to include some place-based work around designing out crime, building upon the Safer Streets work we've done, capitalising on our opportunity to be more articulated in the council's local plan, which is currently in development and will publish in 2025, and so from that can spring off a load of other stuff. Looking at the organisational change work that the council and other partners locally are involved in, like White Ribbon, and I'm delighted to say that the council's accredited in White Ribbon since the last time we brought this subject, and I sit next to James, who is sporting some great merch. You know, we have our banners on. So there is I suppose broadly said, there's a lot of work already going on. This is a real opportunity to bring that together. Thank you.
Susie?
Yeah, I want to thank Caroline for this report, and obviously it's developing really well. I suppose my plea is in moving forward is keeping mindful of the absolute golden opportunity of working with schools, because if we are going to change things by generation, the one place people have to be, on the whole, the majority of children have to be, is in schools, and schools have always been used as the mechanism for social change. And I think it needs to stay really closely, because I think what we have is a generation of young people who are live to the issue, but they're live to the issue, and a lot of girls become more confident in speaking out, but they're immersed in effectively still a strong patriarchy, and that confusion, I think, also leads into some of the issues we see around either specific incidences where there's this kind of clash of cultures, or even going into the arena of mental health. So I absolutely welcome this. It has to be embedded in so much other work that we're doing across the council, so that it doesn't become a tokenistic thing where we wave a certificate around saying that we're white ribbon accredited, but actually, and it is a challenge, and it's a challenge on most of the things that we've been talking about today, is the complex sort of interrelationship of a lot of agendas, which is why I always find it a little bit uncomfortable when people kind of talk about and separate out, for example, mental health from other things. It's not. It's very complex. So I think there's a lot of potential that could be done with schools around not just doing a course on it, but actually engaging with schools. We have Portsmouth Education Partnership here, which is unique across the country. I know there's other versions of it, but we quite regularly have 100% of our schools engaging with whatever issue we're dealing with. So that's my plea. But really good report, and thank you, Caroline, and everyone else for all your work.
Thank you. And Lisa wanted to come back on, so do you want to join us back at the table?
I just wanted to say about the Is This Love campaign that we've been running for 5 years in the city, and that's now being taken on as a priority by the not the ICB, oh God, I can't remember, the Health and Care Partnership. That's it, sorry. And actually we've delivered to all the senior schools in Portsmouth this year during the summer, that programme, but there's more development to go in Caroline's report, so that's going to be the basis of it, and we're going to do more.
That makes me happy.
Fantastic. Terry?
Yeah, just to come on Susie's comment, if that's a point, if that's okay, which is absolutely welcome. I guess we have, in our office, we have so much that we commission in terms of getting out there, agencies and providers to go out and get into schools and what have you. We can't reach them all, of course. And I think, as a council and various partners do the same. We welcome the 2022 statutory guidance around relationships and healthy education being compulsory. I guess for me, it's that bit around the PSHRE curriculum. The partnership stuff, great. We've got all these partners that can go into schools that can deliver this, but what about the ones they don't get to? Is there a consistent approach across that you're seeing across schools in Portsmouth, so that you're not seeing a really high quality healthy relationships education taught in one school and yet a mile down the road it's completely different? And also, I guess, what about those who withdraw from it for, I don't know, faith reasons or various other things? Are we making sure that we are gripping every child through the work that's taking place then? And I've got some questions away from education, if that's okay.
Who wants to answer?
Can I just come back at that? I wasn't talking about curriculum, I was talking about culture. And I appreciate what you're saying, and actually there is a place for curriculum, because where do you start? But what I'm saying is how the biggest change, likely change, is the culture. We don't run schools, and actually I don't believe in telling people what to do is always the best way to change a culture. However, we can use this as a mechanism through our relationships with schools to actually influence that culture. For example, about what we will and not tolerate, how we challenge, what we stand up for. So sorry, I just wanted to clarify that the curriculum stuff I'm really aware of, and I think it's got its place, but that's not quite what my point was about.
Thank you. You want to come back in with your other points?
Yeah, I'll move away from education if that's okay. So you mentioned that there was a brief agenda or an item, a consultation in the Portsmouth Strategic DA Board, but I think it was quite time pressured yesterday, is that right? So I guess my first question is, are there plans for further consultation on the strategy and work streams of external partners?
Yes, because the strategy is going to be co-produced with our key stakeholders and partners, so that in itself is a form of consultation. But then once we have reached a position where we feel that we want to open that out more widely, we will do. But that, I think that will be the first mechanism for that engagement.
And I figured that was the case. So hearing you talk about partners today was clear that would be the case. So I wanted to cover that, if that's okay. And we've heard a lot about place-based today, haven't we? And negatives of one-size-fits-all models. But in terms of not wanting to duplicate or replace existing work, I think it would be important to hear if there has been any work that's taken place to look at other local authorities and what they're experiencing and what they've done to kind of prevent that duplication.
Yeah, so what's really interesting is when you look at other local authority areas that have created a VORG strategy, and then you read the VORG strategy, it's primarily around domestic abuse. So I think a key learning for us in our strategy is to make sure that we remain minded to the full spectrum of violence against women and girls and don't find ourselves creating a strategy that isn't about violence against women and girls. It's actually about primarily domestic abuse. We've done some work locally just to have a look at where we are, comparatively. As you'll see from the report, that building a better picture of need locally is part of the work we're going to do. So I'm not going to steal any sandwiches by reporting early now. But that is part of what we need to do, is to understand, what is our narrative compared to others, and also where there is any other best practice that we can build upon. And actually what is really useful is a piece of work that I'm leading on it for the VORG task group at the moment, which is to look at what is the offer regionally in the Hampshire and Isle of Wight area, just because I think there is a difference of what residents do experience perhaps in the city versus what they'd experience if they just leave the wrong side of the Bedhampton Road. And what we're seeking to do is to sort of map that at a regional level now. So this is kind of happening in tandem, and the point of the work of our VORG strategy is certainly not to end up with something that just sits alone in Portsmouth, but that is absolutely connected to what's going on around it.
And then just one smaller point, if that's okay. I appreciate that these offences are disproportionately affecting women, but is there an area in there for a position statement on men and boys?
There is absolutely, and the report makes it quite clear that whilst we must accept the gendered lens of the reporting that is in front of us, that men and boys are also affected by these crimes, particularly when we're looking at children and boys. So there will absolutely be a place for everybody affected by these behaviours in that strategy.
And then the last one for me is just an offer, really, just to say that in terms of local needs assessment, the OPCC have done some work on this as part of the VORG board, as I'm sure you know, and we're happy to share public profile information specific to Portsmouth, and I'm sure the police could do the same should you need it.
Please send anything you have.
Thank you. I'm really mindful of time and I'm really sorry we're overrunning. Are we happy to approve then the development of this strategy? Yeah, lovely, thank you. So we'll move on to housing. So we've got Sharon George and Sally Scattergood.
Linda, just as they join us, I'll just quickly introduce, and conscious of time, I think we will change tack. So firstly, to introduce Sally Scattergood, Assistant Director of Housing. Sally's teams oversee the management of the Portsmouth City Council's council housing stock and also our private sector housing function. And Sally will be having, or briefly introducing, an item where we'd like to take a conversation into Health and Wellbeing Board development session around the issue of damp and mould in housing within Portsmouth, and particularly how partners can support us in addressing some of the issues there. And also then Sharon George, our interim head of service for housing needs advice in the City Council. That's the team that look after the statutory duties around homelessness, administering the housing register, and also with partners working on things like rough sleeping and street homeless in the city. And the board will be aware, we've been here before, I think, to let you know that we were consulting on a strategy, merging two strategies. And again, Sharon will just introduce a conversation we'd like to pick up in a development session, again with partners buy-in on how we can progress aspects of the strategy. So there's a brief introduction. Over to Sharon, I think, first.
Thank you, everyone, and good afternoon. So the first thing to say, the first thing within your presentation pack is that Portsmouth experiences proportionately very high levels of homelessness. For us, demand has doubled over the last decade, and we received 2,000 applications last year. We expect that to be around about 3,000 this year based on our current demand. The national average, just to give some context, is 11.7 homeless applications received per 1,000 of the population, and we received 20.3 applications per 1,000. So I think that sets out the scene. The next slide tells you that we received 676 homeless applications in the final quarter of 23-24, so the beginning of the year. The causes of homelessness, the leading cause of homelessness is the end of private rented tenancies, followed by friends and families who are no longer able to accommodate people, and people who are homeless due to fleeing domestic abuse. And you'll see there's a table that demonstrates that. You'll all be aware that the council has a statutory duty to provide interim or temporary accommodation to homeless applicants, and there's a bullet-pointed list there of some of the accommodation that we provide for people who are assessed as being in priority need. Over the last 5 years, demand for temporary accommodation has increased by almost 300%. And that chart, the graph shows you the number of households who are in temporary accommodation. We are aiming to reduce our reliance on bed and breakfast and hotel accommodation use, and we continue to add to our portfolio of good temporary accommodation, ensuring that we provide good facilities and appropriate support. And I know, Helen, you and I had a conversation a long time ago about the implications for people in temporary accommodation. Sadly, because of the increased demand, we've still had to rely heavily on bed and breakfast and hotels to accommodate predominantly singles and couples. We've tried to increase our provision of non-B&B temporary accommodation by 70 units, which is 61%, and the demand, unfortunately, has outstripped that supply, but we are seeing the average number of days a family is in bed and breakfast emergency accommodation start to come down, and that's something that we focus on. We focus on everything as a team, but that's one of our priorities. So if we move on now to the housing register, once a person is assessed and a duty to house, the applicant is registered. We've currently got 2,300 households on it being in need, and we aim to ensure by people being banded, we aim to ensure that those who are most in need are allocated first, and we do have an allocations policy which supports that. You'll see in the slide it talks about the banding. We are seeing more people in the higher or exceptional banding, and we're understanding what that is for. As James has outlined, we are implementing the homelessness and rough sleeping strategy, and we're working to develop models of housing that suit people at different stages in their lives. And Sally will talk about developing the stronger models for support for long-term successful tenancies. We currently have 2 separate strategies which cover homelessness and rough sleeping, and we are looking, the Homelessness Act from 2002 explains what we need to consider in our review. We're currently reviewing those 2 strategies and sets out the frequency and publication every 5 years. We must include within the strategy how we'll secure sufficient accommodation now and in the future, and we're working very hard to understand that. The review is underway, and it's shown a need to combine those 2 strategies, and a review into homelessness is also underway. The The findings of the review will inform the strategy, which is due for consultation before the end of this year. So far, we've spoken to service users, partner agencies and other stakeholders, and that has included a number of in-depth conversations with people who have used our services. Formal consultation will commence in the late summer, and we really urge it will come to this board with the permission of the chair, and we will really urge people to participate within that. We have some emerging themes which are there for you to see, 6 emerging themes, and one of the key areas within that is that we identified that people who have complex needs living in temporary accommodation without support were failing to maintain those tenancies because they needed support to sustain that. So we began a pilot with Two Saints, which is one of our commission providers, for them to offer supported temporary accommodation. We provide 32 units with kitchen and laundry facilities, and key workers support the families and individuals with life skills. So of the 59 homeless applicants to have moved through the accommodation scheme, 53% moved to social housing or into another private rented tenancy, and another 24% moved into supported housing. That includes people that went into alcohol and drug rehabilitation. The key thing within that graph is around the number of people that were evicted. We only had 2, and by being evicted, that makes you intentionally homeless. We do some further work. I really recognise this is a small sample, but I think we are showing some really great results in terms of what we achieve for individuals and families within the city, and it's something that we would want to progress. So I'm going to pass to Sally, who's going to take you through.
Hi, so as Sharon says, we do work across the city to support landlords, both as a landlord ourselves, we support tenants, but we also work with private landlords to support them in trying to provide the best environment for their tenants and support tenants in those tenancies. But today I just wanted to take the opportunity really to focus on updating you around our response to damp and mould throughout the city. As you will no doubt all be aware, it's come under a lot of focus both nationally and locally following the child death in Rochdale, where the coroner made the direct link between the child's death and the conditions that they were living in their home. So as an authority, we have different responsibilities depending on the tenure type around how we manage damp and mould. So I won't go through all of the slides, but I will just sort of summarise. So our role regarding private sector tenancies is one where we like to work with landlords to support them to ensure that their properties are fit for their tenants to live in, that they provide safe and comfortable environments for their tenants. And so we receive complaints from tenants who will come through to the private sector team. They will report incidents of damp and mould in their homes. We'll always try to encourage them to address that through their landlords initially, but where that looks like it's breaking down, we'll go out and step in and carry out an inspection. Initially, we'll try and work with the landlord to see if there are definite issues that need to be addressed, then we'll ask the landlord to do that. But we also do have the ability to enforce that where we believe that there's a breach of the HHSRS, so which is the Housing Health and Safety Rating System. The difficulty is at the moment is that the system that we work in, damp and mould, doesn't often fit the criteria for a high-level hazard. So it has to be really, really extreme for it to be identified as a hazard 1 or 2. So often we are reliant on providing that advice to landlords and their goodwill to actually do something to support their tenants. We do, of course, provide advice to the tenants about how they manage moisture levels in their own homes. There are lots of things that the tenants individually can do, and we'll also signpost them to other services if we think that there are issues around fuel poverty or that they just need general advice in other areas. In terms of social housing in the city, we're obviously the largest housing provider, social housing provider in the city. So we have looked at our own response to damper mould when it gets reported to us. So we also receive reports from our tenants. And whilst we already had a response in place, so they would always be investigated and we provided advice, the incident in Rochdale caused us to reflect on what our processes were. So we've reviewed those. We've revamped our leaflet that provides advice to all tenants in our properties about things that they can do to manage moisture levels in their home. But we've also sort of improved the process, so when they report to us, they will always get an inspection from a surveyor. So a surveyor will always go out, assess the extent of the problem, provide the relevant advice, and again, they'll signpost where needed to Switched On Portsmouth, for instance, or to other services. But they'll also look at other things that we can do in the home. There might be repairs that are needed that are contributing to the damp, but there might be things that we can just do to improve managing the moisture in that home, like increasing ventilation, extraction fans, an additional radiator, that kind of thing. I have, in these slides, you'll see that we describe the actual process that we go through. I won't go into all of that now. The other thing that we're looking at doing was improving training and understanding of the issue amongst all of our staff. So surveyors were already pretty genned up on this. They were able to go out and provide the right advice. But we also have large numbers of housing officers that are going into people's homes on a regular basis. So we've now improved the information available to our housing officers, so they've all been briefed and they understand what the risks are and what they need to do to support tenants to get those issues rectified, to manage the moisture levels in the home, but also to get a surveyor out. So we've improved that process, I think, so that we're not just doing it from a surveyor's point of view. We've got housing officers who are also genned up. But we're also working on developing some training that we want to provide to all PCC front-facing officers and health workers. Because we're very much aware that we're only getting into a proportion of homes within the city, and lots of other workers are actually going in and into those homes, and we want them to be equipped to identify where there's a risk and provide the relevant advice and to be able to signpost residents in the city to the relevant help. So that's one of our pleas really for today for the board, is to get your support to engage all the teams that you think might be relevant with that training once we've produced it. And I think that's it from me today. That is our plea today.
Thank you.
Any questions?
Yeah, thank you for that interesting report, and we'll look forward to having some other training across the piece. I think as GPs go in quite a lot of houses, don't we? And at least knowing how to signpost would be very good. Terry, did you want to come in?
Very quickly, if that's okay. I think it's a really, really good report. I guess for me, as an aside, it would just be helpful to know what the picture looked like specifically in terms of rough sleeping post-pandemic. I think everyone, were quite clear that Portsmouth City Council did a really good job gripping people, wrapping them up, taking care of them during lockdown periods. Was that used as an opportunity to sign up for the support needed, right partnership agencies and all of that sort of stuff, and kind of get that paperwork sort of side of things done, or did we return back to a similar picture that was seen pre-pandemic?
We were able to develop the rough sleeping pathway so we can provide accommodation in the city for roughly 105 individuals at one time. We really wanted to I hesitate to use the word opportunity, but we wanted to use that to engage with individuals, and we've been able to work with our colleagues within other teams, offering health support, offering support around addiction, all sorts of support, and our commission providers continue to provide that on a daily basis. We still operate a rough sleeping day service, which is within the city, and people can access that for any need that they have. But we are proactive in going out with an outreach team on the street to offer that support to people. So yes, it's strengthened since then.
It's really, really reassuring. Thank you.
Thank you. Sarah?
I mean, just very quickly, again, to reflect on the quality of the report and the information and that phenomenal success of the supported temporary accommodation, to see those outcomes and to see such a very, very small number in terms of those evicted is really positive. So I do hope that we can somehow make that grow and see that reaching into more of our vulnerable communities. It's an excellent piece of work. And just to say, we will absolutely back the training as well in terms of that damp and mould. I know it's something that social workers see, health visitors, all of that midwifery, and we will lean into those integrated services and ensure they're signed up. So yeah, great work.
Thank you. And there was a suggestion about some development session time. Kelly, can we?
Sorry. Yeah, so this is part of that sequence we've been doing of taking our health and wellbeing strategy themes, looking at as the broader board, and then taking some of those things in for a more in-depth conversation about what individual partners can do support from that angle within that session. So yeah, we've scheduled a session where we'll get a chance to look at this in more detail and just put out any of those other themes where we can be supporting more. But yeah, I think really helpful to continue this sequence of bringing the themes forward, because it is giving us an opportunity to look at the strategic work in a way we probably haven't done before. And I think just to trail at the next meeting, we'll be looking at the positive relationships theme.
Lovely. Thank you. Thank you for that. So we're moving on to stroke recovery service, and I'm very sorry for keeping you ladies waiting. So we've got Jane Walker, who's Head of Adult Care and Support, and Rachel Roberts, Deputy Director for Adult Social Care, who's going to join us.
Thank you for the time you've given us today. We've brought an information paper which is highlighting a decision that we've made within adult social care and kind of gives the rationale for that decision and talks about the services and support that are available to people in the community. And I'd just like to thank Jane for writing the report. Given how short of time everybody is, I wasn't proposing to go through the report. It's quite short, so I was going to invite questions from people.
Thank you. Any comments or questions? Oh, Ines was up first then.
Sorry, Roger. Thank you. Just very a question really. The rationale for the decision, I just need a little bit of clarification. Is this because there is no longer a need for this specific type of support, or is this because strategically you're making a decision to move in a different direction? I wasn't clear on if I was using this or needed this service, why this service was being withdrawn. I know there are alternatives out there, but that's the message that I didn't quite pick up from this.
Okay, I think fundamentally the bottom line is that we can no longer resource this service. So we've been managing to deliver this service probably for the last kind of 6 years through the management as a pressure and through, you know, moving money around and trying to identify resources. I think the situation has become more challenging. Particular area that I'm responsible for has got significant budget cuts that we need to sort of focus on in order to bring our budgets online this year, and there just isn't the money. So that's one of the kind of fundamental reasons. There's no doubt that the service has provided a bespoke support service to people who have had a stroke. But there are other organisations working in that space, and there are other support services. So essentially, I think what I was trying to demonstrate in the kind of rationale is that whilst we've had to make this very difficult decision to withdraw from what is essentially a discretionary service for adult social care, that there are other options available for people in the community to access some specific stroke services, but also some more generic support services that are locally available in the city. So that's kind of the rationale. I mean, the backdrop to this is that there is a model that was published in 22 which does advocate kind of a stroke recovery service delivery through the voluntary sector, but currently within Portsmouth that model hasn't been rolled out, and it doesn't mean that at some point in the future the requirement is that within the lifetime of the NHS plan that model should be implemented. So it may be that later on in the future a decision may be taken to go down the route of commissioning a more specific stroke recovery service, but at this time we do not have the resources currently to continue with the service.
Thank you. Did you want to come back in on that?
No, thank you. That's helpful. I think my concern in that is if we know there's an intent to commission this, albeit maybe from an NHS perspective, and that something like this is going to come along shortly, why would we as a board not as adult social care, let this be a gap instead of concentrating on delivering what we know needs to happen, I guess would be my question. And I know we're short of time, so that's probably needs a bit more debate, but my worry is we drop services, and it's unfortunate it's a voluntary sector service, in order to pick them up later. So I guess that's for something for the board to have a ponder about, or a debate at a time when it needs to.
Roger?
Thank you. Well, not quite the same point, but very, very similar. I was thinking around the rationale, but pointing out that there has been a local petition about this. So, you know, the patient voice, carer's voice has been heard, and I know the service was extended until the end of the year. Looking at the document you referred to, the National Service Model for an Integrated Community Stroke Service, which we haven't implemented in the city, the team composition suggests that there should be a life after stroke services, including voluntary charity sector support services, carer support services, stroke education, information provision, signposting, peer support. So it's really kind of re-emphasising Innes's perspective that he shared there about, you know, if we're looking at this provision at some point, are we really shooting ourselves in the foot by decommissioning it because there's no money, which seems to be the rationale.
Kelly, you wanted to come in?
Yeah, thank you. And just really mindful, obviously, of the time left available, but obviously the importance of the issue. I think the way that we've structured ourselves from a governance perspective locally is that obviously this is the board where we highlight those issues of particular concern in the local system, and actually the resourcing issues then flow into the Health and Care Portsmouth partnership. So given that the next meeting of that partnership is the 12th of July, I would suggest that maybe it'd be helpful to take that into that conversation for a further discussion about those resourcing issues, because I think then we can probably bring a report back to the board on the summary of that conversation, if that's a helpful way forward.
Yeah, that sounds good. Matt?
Thanks, and thanks for the report. I mean, I asked for it to come to this forum for the reason of it is a cross-organisational situation. I was so I met with actually one of my local ward residents who actually happened to work for the Stroke Association, and that caused the conversation, which then ended up with the extension at my suggestion, and I'm pleased it happened until the end of the year, because originally it was going to be at the end of, well, in 2 days' time was when it was going to finish. So, and I'm really pleased we managed to do that extension. I think it's a really difficult one, and as we see from here, that the frustrating thing from my point of view is the pathway was published last summer nationally, and that is for the systems generally, and that in Hampshire Isle of Wight, and I think we've talked about Portsmouth, but let's be honest, it's Hampshire Isle of Wight, there has been no progress on it. So nothing has happened. We are the only place in Hampshire Isle of Wight that currently has this service. The other in other parts of the area that they've already ceased, and in some cases many years ago. So it's frustrating, I think, from the systems point of view, that nothing has happened with that. Bearing in mind, other places around the country are making movements on that pathway. So I think the bringing it to this body is just to highlight about where it comes from. Obviously, as you can see, part of that is from the Better Care Funds, from effectively underspend there. The rest of it, as Jane has pointed out, has been through us scrabbling around and finding a bit of cash here to keep it going. It's not a statutory service. It hasn't had an underpinning funding for it really ever. And actually, from my point of view, and we talked about the partnership and the board and everything, is about having those conversations, not just within, and we're talking about our integrated care, local integrated care partnership work, but what we can then bring up to the Hampshire Isle of Wight level to say we need to have a strategy for this across Hampshire Isle of Wight, and some movement needs to be made. The government has given, now it's a frustrating thing as ever that government gives you a pathway but they don't provide the funding, But that is something that we are expected to do, we as in the system. So it's something that I think we can have more conversations about locally. I have to say, certainly from everything I've had, the work with the Stroke Association locally has been very constructive, that they have been very constructive in sort of working forwards. Obviously, they would love the service to continue as it is, but it's about making sure you've got that extra time to do the pathways. So completely agree with it coming to the meeting on the 12th, as Kelly has said, and think that would be really good. And then, but also for us to be working and feeling upwards and saying, come on, let's get on and get this care pathway done across Hampshire Isle of Wight, because that is what's going to have a lasting influence from there.
Thank you. Jo?
So just really briefly, I wonder if it's possible to understand in the work that goes to the 12th, to understand the potential impact on the existing NHS teams if this is withdrawn. Because obviously we are equally stretched, and our CRT and CNRT in particular, but also the PHU teams. If withdrawing this is going to have a knock-on effect on our NHS provision, that's a real concern, because we're also, you know, on our bare bones of things as well. So it'd be really good to understand that as part of that piece of work.
Thank you. Yeah.
Just to say, we have consulted with our health colleagues around those sorts of issues, and the feedback I've received so far is that the expectation is that it's more likely to fall on primary care in terms of, you know, that additional. So again, another area where everybody's under pressure. I appreciate, but I think what we don't need to lose sight of is that there is a robust stroke service in place. I appreciate that they are stretched and CNLT, etc. So what we'd really be looking for to support this sort of, you know, potential gap is more from the voluntary sector, I would have thought. So I think that's where we'd be looking to have those conversations with our colleagues in the voluntary sector to see what impact that would have and whether they've got the capacity also to pick it up, because we're stretched everywhere, aren't we?
And I did get involved in a meeting with Andy Biddle and the team to express my concerns about it falling back on primary care. But I think there was also concern about, obviously this is a very good service for people with strokes, but there's lots of other conditions that perhaps aren't getting this level of service, and the equity across that as well in our current situation. So, so it's all about. So another conversation in the health, you know, that would probably be helpful to have that conversation. But it is about equity across all of them, isn't it, as well? So. Well, thank you very much. Any other questions on that? No? Lovely. So the next meeting, Anna, is... Because it says March. Yes. Have we not got another one in 2023?
Yeah, we've got September.
September, yeah. Oh. So apparently we have to formally agree 2024 dates. So they're at the bottom of the agenda there. So there's 6th of March, 26th of June, 25th of September and 27th of November. So if there's any problems with them, if you could let Anna know, perhaps. Thank you. I'm sorry for overrunning so badly. But interesting conversations. Yeah.